are the what are the management options for that. Um, the um, the bulk of the figures in this slide were collated and put together by one of my partners, Dr. Horry, so he deserves most of the credit for collecting the information that we're going to present tonight. So we know that in general, meningiomas are a type of benign tumor, but just because they're benign and generally non-malignant, that doesn't mean they can't come back. So the question we're going to focus on tonight is how often does it recur? What are the factors that lead to recurrence of meningioma? And what are the treatment options if the meningioma does come back? So before we talk about the management of recurrent meningiomas, let's just kind of talk about in general what are the options to manage a meningioma that is diagnosed for the very first time. Uh, so this is a general flow chart on how to manage meningiomas that are initially diagnosed. Generally, an MRI scan is obtained, and that leads to a diagnosis. If if the meningioma is small and not causing any problems, one option is to just watch it with MRI scans. But if the meningioma does grow on the MRI scans, then you would come down to here and consider treatment. Alternatively, if you have an MRI scan for a meningioma and you are having symptoms, or the tumor is quite large, or you're just anxious and want to get it treated, you can go straight to treatment options. In general, if a patient is in good clinical condition, not having a lot of medical comorbidities, and if the meningioma is in a easily operative location, then we typically consider a surgical resection. And the main reason for that is it allows us to get tissue for a pathology diagnosis. If, on the other hand, the patient is not in good shape neurologically, or for example, if they're elderly and cannot tolerate anesthesia, or if the meningioma tumor is in a area of the brain that is not easily accessible with surgery, or in which surgery would be high risk, then we typically consider radiation. And we'll talk about the two types of radiation: stereotactic radiosurgery and fractionated radiotherapy. So surgery is preferable if the tumor is large, because it allows mass reduction. So mass reduction is exactly what it sounds like. The tumor has a certain size, it's putting pressure on the brain, and when you remove the tumor, you're essentially decompressing the brain. You're getting the pressure off of the brain. Surgery also allows you to obtain tissue to send to the pathology department. They will do their special stains and study it under a microscope and give you a pathologic diagnosis. So they'll come back and say, yes, this is a benign meningioma. Um, if you go with radiation, and most radiation for meningioma is focused radiation, it's a high precision radiation called radiosurgery. The primary advantage is that the radiation is minimally invasive, and radiosurgery is a good option if the tumor is small to medium size and not causing a lot of neurologic problems. It's also potentially the preferred option for tumors of the skull base that can be challenging to resect with surgery without causing a lot of neurologic morbidity. So here's the flow chart of what we do with patients after they've been treated. So let's look at the radiation pathway first. If you have radiation, you'll be watched with periodic MRI scans called surveillance with MRI scans, and the essentially you're followed with MRI scans to make sure the tumor doesn't grow, and you're followed clinically to make sure that you don't have any clinical symptoms. So it's pretty straightforward. You watch with MRI scans, make sure the tumor has responded to the treatment. Now, if you had a surgical resection, it's a little bit more complicated because we then look at the pathology of the tumor. Most meningiomas are graded according to what's called a WHO classification that stands for World Health Organization. And meningiomas are graded on a scale of one, two, or three. Most meningiomas are grade one. Approximately 85 to 90% are grade one. And grade one meningiomas would be classified as the slowest growing type of meningiomas. Unfortunately, they're the most common type. Grade two are growing a little bit faster than grade ones, and grade three are the fastest growing tumors. They're fortunately only about 1% of meningiomas are grade three, and these are much more aggressive meningiomas than the grade ones. So the depending upon the grade of the meningioma, that determines whether or not surgery alone is sufficient or whether you have to follow the surgery with um, radiation if you're not able to get all of the tumor out. So following surgery, what is the chance that your meningioma will recur? And there were two factors that affect the recurrence rate of meningiomas after surgery. We'll talk about these two and I'll explain them to you. The first is the tumor grade, what we were just talking about on the last slide, whether it's a one, two, or three. And the second factor is what's called the extent of resection. So when you undergo resection of your tumor, was the surgeon able to get it all out, or were they only able to get 75% out, or was it just a biopsy? So we'll look at how the extent of resection impacts the chance of a meningioma growing back. Okay, so let's first talk about the grade of the tumor. Remember, this is a pathology grade based on the World Health Organization or the WHO classification. If your meningioma is a grade two and you have surgery, and you get a good resection, complete resection, the chance of a grade one meningioma coming back with a good resection is only about 2% on average. If it's a grade two meningioma, they tend to be a little bit more aggressive than the grade one. You can see the chance of it growing back is 7 to 10% per 100 person years compared to the grade one. And then when you look at grade three, you could see, the chance of it coming back is much more. Over the first 5 years after surgery, there's a 63% chance the grade three meningioma will start to grow back. So big difference between grade one, two, and three. And again, grade three tend to be very uncommon, even though they're the most likely to recur. We also know that the location of the tumor influences the recurrence rate because the location of the tumor determines how much of the tumor you're able to safely get out. A tumor right on the surface of the brain is called a convexity tumor, and that is able to be removed completely in many, many cases. And so, because you're able to get all the tumor out, there's a low recurrence rate with that type of meningioma. Now, some meningiomas occur at the base of the skull. We call them skull-base meningiomas. These are difficult to completely remove, and even if you have surgery, there's a high chance of not being able to get the tumor out from all the nooks and crannies of the base of the skull, and that means some tumor gets left behind, and it can potentially grow. Okay, so we talked about the grade. We know grade one tumors are less likely to recur than grade two or three tumors, and that's based on pathology. We've been talking about extent of resection. How easy or difficult is it to get out all of the tumors? So in 1957, a physician named Dr. Simpson his name was Donald Simpson, not Homer Simpson, but his Dr. Simpson classified a grading system for meningiomas. And this grading system um, uh, just is based upon the extent of resection. So if you're able to get the whole tumor out and any abnormal structures adjacent to the tumor, are you able to remove with it? That's called a grade 1 resection. Just think of it as a complete resection. If you're not able to get all the tumor out, let's take a look at grade 3. You got the tumor out, but where the tumor is attached to the bone or the dural lining, which is the lining of the skull, you weren't able to get that part out. That's called a grade 3 resection. If you're only able to get part of the tumor out, like half of the tumor or 3/4 of the tumor, it's a partial tumor removal. That's a grade 4. And if you just biopsy the tumor, essentially taking out a small fragment of the tumor but leaving the majority of it behind, that's a grade 5. So this is called the Simpson grading system from 1957, and it's still the most common grading system that we use today for meningiomas. Okay, so what does this mean in terms of the Simpson grading system? Let's look at this grade of 1. So remember the Simpson grade of 1 means you've got pretty much the whole tumor out, and the MRI scan after the surgery shows no evidence of residual tumor. That's a grade 1. Now, if you look at the results in that column, if you have a grade 1 meningioma and you get a Simpson 1 resection, the chance of recurrence is pretty low. Most of the studies show anywhere from a 0 to 5% chance of it coming back. Now, if you're able to get a Simpson 4 resection, that means you really only took out part of the tumor, and the MRI scan after the surgery shows that there's still some tumor left. You can see the chance of recurrence or growth is 30%, 40% in some of these series. And Simpson level 5 is just a biopsy or just taking out a tiny piece of the tumor and leaving the majority of it behind. Of course, all the tumors in that category showed some growth. Okay, so that was after surgery. Let's talk about what happens if you choose radiation or radiosurgery for your tumor. Um, First of all, most tumors that undergo radiation are smaller tumors than those that undergo surgery. And smaller tumors, one could argue, is easier to control than a large tumor. So an argument could be made to the point that, well, the tumors undergoing radiation already start off with a competitive advantage because they're smaller and more likely to respond to treatment. But here's some of the data that shows that essentially, if you have a small to medium-sized meningioma that undergoes radiation, the chance of killing the tumor or not having it grow is very high. In this study of 800 patients, it was 99%. So only 1% of meningiomas progress despite radiation. But again, one could argue this is because you self-selected out smaller tumors that are more likely to do well. One quick slide on terms of like what we're looking at potentially in the future. At present, when we talk about meningiomas, we say, well, the treatment options are radiation or surgery. We don't talk a lot about medications or types of kind of drugs that are used to manage meningiomas because for the most part, there have not been any good drugs that have shown to be effective long-term for meningiomas. Having said that, this table shows a number of ongoing clinical trials in which a number of these potential drugs are being tested to see if they have a benefit for meningiomas. Okay, so that's how we kind of determine the risk of recurrence based on location, extent of resection, and the grade of the meningioma. But what happens now you're in the point where your meningioma now did come back? What are we going to do? The choices we'll talk about are repeat surgery, radiation therapy, either after surgery or after prior radiation, and systemic therapy, which is those drugs that we're talking about. So obviously, when the meningioma recurs in a patient, it's now a recurring in most patients several years or multiple years down the line. So patients are often older when they undergo the treatment for the recurrent meningioma than they were during their initial treatment. So if a patient underwent surgery for their meningioma when they were 65 years old and it recurred 12 years later, well, now they're 77, pushing 80, that may come into play. So we do look at the age of the patient, any medical comorbidities, other medical conditions that would make the choice of treatment preferable one way or the other. And then again, patient preference is still an option here. So for many meningiomas that need repeat treatment, both surgery and radiation could both be very good options for the patient, and therefore patient preference might ultimately be the main factor in deciding what a particular patient wants to do. We know from the prior treatment, particularly if the patient underwent surgery, we know what grade the meningioma was last time. We can see the size at the recurrence and compare it to the size at the original diagnosis. And then again, we look at kind of the general location um, of the tumor. And we do look at kind of what prior treatment a patient has had. For example, if a patient started with radiation and the tumor was next to a important structure such as the brainstem, it's potentially possible that more radiation can be potentially risky to the surrounding normal critical structures of the brain, and therefore we may recommend surgery. Um, Other times, the tumor is not next to some critical structures and repeat radiation can be delivered. But we definitely factor in the previous treatment when it comes to deciding which treatment route to go with. Okay, so what if you had surgery for your meningioma and now you're down the line a number of years and the meningioma looks like it's coming back? Certainly, a very common option is let's just do another surgery, particularly if the first surgery was highly successful and the patient did well and there was a long time interval. Let's say last surgery, the first surgery resulted in 15 years of excellent, neurologic health. If the patient's in good shape and a second surgery could be done, maybe there'll be another 15 years of benefit. So we do consider repeat surgery as a standard option for many tumors, particularly if, like I said, the patient had done well and had gotten many years from their prior surgery. You have to also, however, factor in a couple of things. One is the patient may be a lot older than before the first surgery. The patient may have other medical problems before the first surgery. And there's always a chance that a meningioma, while it was a grade 1 10 years ago, it could have upgraded to a more aggressive type of meningioma at the time of recurrence, and that could potentially explain the recurrence. So um, you can't totally assume that the previous grade is still the grade at the time of surgery for the second operation. Now, what about if your tumor comes back? Let's see, you've had surgery. Now we're going to do radiosurgery for the tumor. What are the strategies and risk factors there? Um, if if a tumor does come back and you do radiosurgery, the control rates for the tumors in some instances are still very high, but in other studies we start to see a little bit of a drop from that high 90s control rate from before. This can be because repeat or radiation for recurrent meningioma can be more difficult to target the tumor. A initial tumor often is very easily outlinable on the MRI scan, whereas a recurrent tumor often has tumor edges that are more difficult to delineate and identify. And so if you have a greater difficulty targeting the tumor, that may result in potentially a lower control rate. Uh, this is another slide now looking at grade 2 meningiomas, and compared to grade 1 meningiomas, grade 2 meningiomas, they're more aggressive. They don't respond as well to radiation than the grade 1 meningiomas. Um, there's only very little data on repeat radiosurgery for grade 3 meningiomas, so I'm not going to really cover that. Um, so the summary of the radiation therapy is that you can use it in selected instances for recurrent meningiomas, even if the patient has had prior radiation to the meningioma. You can certainly use radiation as a treatment for a recurrent meningioma that has been previously operated on. And sometimes that's actually easier than a patient that has had prior radiation because you don't have to factor in the previous radiation doses. I want to just talk about one kind of sample case. Then we will open it up for some question and answers. So this is a patient that we treated at our institution. She's a 40-year-old female, and she had a grade 2 meningioma. So that tells you it's going to be a little bit faster growing than a grade 1 and more likely to have some recurrences. Um, so this is what things look like on the initial MRI scan. This was the tumor shown here. You can see it's quite large. It's occupying a good area of the brain. The normal brain structures are compressed and shifted over. So this patient was initially treated at an outside hospital, not at Stanford, and the neurosurgeon only was able to get a minimal resection, probably because of the potentially bleeding from the tumor. These can often be bloody tumors. So you can see this is only a partial resection there. This would be a Simpson grade 4 resection, meaning, there's obvious tumor left on the scan. And this patient then at that time had some radiation. So we had a partial surgical resection, now followed by radiation on the remaining tumor after the surgery. So the patient was followed with periodic MRI scans. And 1 year after the first surgery and the radiation, she came into an emergency room, and this is kind of what the scan looked like. There were two areas of white, this area in the front here and the area in the back. These are both areas that enhanced on the MRI scan. Now, we have ways on the MRI scan to look to see if just because something enhances doesn't necessarily mean it's tumor. And in this case, the front part here ended up being just radiation necrosis, meaning the radiation they got previously injured this area of the brain, and it necrosed, it died, and it created this fuzzy white area. However, this area of the brain in the back here is not consistent with necrosis and was thought to represent live tumor. So they underwent a second operation to remove that tumor. And this is what it looked like after the surgery. The majority of the tumor was resected. There's still a little bit of spot here. This is the radiation necrosis. But at 3 months, we start to see that area of tumor starting to grow back again. It's only been 3 months since the second surgery, and this time we treated it with focused radiation. The first time the patient had conventional radiation, now it's very focused radiation, and by being very focused, it allows us to dial up the dose of radiation to a higher level. And after the focused radiation, it looks like there's finally some, long-term control here. The area of necrosis, the injury, is also healed up nicely. So this is the best brain-looking MRI scan the patient's had in a while. So this is just a case that we just showed to show that there's been how multiple types of management potentially need to be used to manage the patients. So take-home messages on regarding what to do if your meningioma comes back is we take obviously a step back and consider all the options on the table for a patient. We look at the prior grade of the tumor if it was previously resected. We look at how big the recurrence is considered compared to the original size of the tumor, what kind of neurologic condition the patient is in. We look at other factors, grade of the tumor, how fast it's growing back. And often for the multiple meningiomas, as we saw in that case example I just gave at the end, using multiple choices is necessary to get long-term control. So in that case example, the patient had 2 surgeries, 1 dose of conventional radiation, and 1 dose of CyberKnife-focused radiation to get long-term control. Okay, I'm going to stop with the formal presentation. And as we typically do with the support groups, we try to leave half of the time for question and answer. Obviously, these answers are not going to necessarily be very specific medical advice because this is just a webinar, but I can give pretty broad, generalized answers to many of the questions that you might have. So we'll stop the presentation now and go to the question and answers. And if you have questions, you can just submit it to the question and answer button at the bottom of the webinar screen, and I'll answer the questions in the order in which they come in. So the first question was, can you comment on the optimal length of time to wait after IMRT for optic nerve sheath meningioma to determine whether or not the radiation was successful and or recurrence has not occurred? So a good question. So in general, it takes radiation a while to kill a benign tumor like a meningioma. And I typically tell patients it can take a couple of years for a benign meningioma to die after radiation. So in order to determine whether or not radiation was successful, we are looking for long-term control. So not what the MRI a year after radiation looks like, but what the MRI is 5 years, 10 years after the radiation looks like. That's long-term control. So if what we expect following radiation is no change in the size of the tumor on each MRI scan, possibly some mild shrinkage over the long run on the MRI scan. If we start to see on the MRI scan that the treated tumor is actually increasing in size, that in theory could be related to some swelling following the radiation. But depending on the timeline, if that increase in the size of the tumor appears on multiple MRI scans and is outside of the typical timeline for swelling, then we would consider it a recurrence. But there's not some sort of magic formula we use. It's kind of a combination of multiple MRI scans and then looking at not only is there a change, but the extent of the change. And the next question, I had a surgical resection of a 5 centimeter meningioma 7 weeks ago from the back, from the posterior fossa. It's the back of my head. There's about a 10 millimeter rind left along the sinus, which is a blood vessel. The WHO is grade 1. Would the remaining tumor be the same grade as the part taken out? I also have a 3 centimeter meningioma as well. So when we grade a meningioma, the part that's taken out is sectioned by the pathologist, and the tumor undergoes its grading scheme. The assumption is that the part of the tumor that's left behind is the same grade as the part that was taken out. There's no reason to believe that the part left behind is somehow different. And your case where a tumor is left along a major blood vessel is a very common situation The sinuses are very critical structures of the brain, and if they're injured during a tumor resection, that could result in a neurologic deficit. So it's very common to potentially leave a remnant or rind or carpet of tumor along the sinuses. Um, Now, you mentioned it's about 10 millimeters, so that's about a centimeter that's left. You and your doctor would need to determine whether or not that residual meningioma should be treated right now with focused radiation. I would say that at 57 years old, um, you likely have many decades to go, so that 10 millimeter rind is likely to grow over time. So in most cases in this situation, I advocate to just go ahead and treating the residual with tumor with focused radiation. Also, if you have a 3 centimeter meningioma, that is getting to that's a second tumor. That's also of a size that is get almost on the cusp of becoming too large for radiation. So if you want to treat that non-invasively and avoid a second surgery, treating that with focused radiation, now could be done. And they could actually treat your rind plus the second tumor at the same time with the radiation. The next question is, if a very small amount of tumors growing back along the sinuses, I guess the veins, is that considered treating like it's a small tumor? Which type of radiation, proton or photon radiation, is best? Grade 2 meningioma, small growth seen after 1.5 years. So this is a good situation to use focused radiation. It's a small amount of tumor left. You've already had one surgery. So to avoid a second surgery, it's good to consider some focused radiation. In terms of the type of radiation, the exact type that you're talking about, protons or photons, or is not important. The more important is I think how experienced the team is that's delivering the radiation. Most centers use photon radiation. We typically use photon at Stanford, but a small growth in a grade 2 meningioma is a good target for radiation. Okay. Next is what genetic testing should be done on my pathology, given that I have 2 large meningiomas and my mother has 1 meningioma as well. There are there's not a specific genetic test for multiple meningiomas because you can have multiple meningiomas in several different circumstances. The first is just you have normal genes and just happen to get 2 meningiomas. That can happen. There are certain genetic disorders that predispose patients to multiple meningiomas, and one of them is, for example, neurofibromatosis, which we typically associate with neurofibromas, but they can also result in multiple meningiomas. So most academic hospitals that have a genetics department or a genetic oncology department can have genetic counselors and physicians that could evaluate you in their clinic and go over kind of the different options. Most genetic testing is just a blood test. It's not doesn't require necessarily specific testing on the tumor. Okay, next question. How do I know if you're radio resistant? And I presume that means how do I know if my tumor is radio resistant? And I think first, let me just kind of define what physicians mean by the term radio resistant. Radio resistant is short for radiation resistant. And the thought process is that different people might have a different response to a given dose of radiation. So a quick analogy, sunlight is radiation. So if 2 people are out in the sun for half an hour, one might be okay and the other might get a sunburn. Why is there a difference? They were both out in the sun for the same amount of time. Why did one get the sunburn and one didn't? So the concept is similar among meningiomas. If you treat all meningiomas with a certain dose of radiation and 5 out of the 100 grow, does that mean that 5 are radiation resistant, or is that just based on probability? If I tell you that the radiation has a 95% chance of working, we would expect 5% of the patients to show growth despite radiation treatment. Now, whether those 5 are having some sort of genetic factor in their genes that make it harder for radiation to kill a meningioma, or whether those 5 were just statistically the 5 that we were going to see, is not clear. So the short answer is there's no way to really tell if somebody is radiation resistant versus whether it's just bad luck probability that you ended up in kind of the 5%. The radiation resistance is a term that physicians created to potentially try to explain to themselves why certain patients didn't respond to the radiation. But there's no kind of way to show that your tumor is more resistant to radiation than anybody else. Is proton therapy the same as SRT? Okay, so SRT is stereotactic radiation therapy. Proton therapy is a form of radiation. The terms somewhat overlap because what one person considers SRT may be different from what another person considers SRT. But in the grand scheme of things, proton therapy is a form of radiation that can be used for meningiomas. Next question, is there a difference between the typical side effects of the 2 different types of radiation you mentioned? So focused radiation is what's called the stereotactic radiosurgery, relies on high degrees of accuracy. So you can target to less than 1/50th of an inch of targeting error, so half of a millimeter. That extreme accuracy allows you to deliver high doses of radiation because you're so accurate that you're not exposing the normal brain and other structures immediately around the tumor to any significant dose of radiation. The other form of radiation that I mentioned is called radiotherapy, and radiotherapy is the older form of radiation that we kind of all typically think about, and that's where you're getting, you're going in for multiple weeks at a time and getting 30 small doses of radiation. That is, what's called radiotherapy or conventional radiation. And that exposes a lot more normal tissue to radiation, but it does it by breaking the radiation up into smaller doses over, let's say, 30 days, so that you don't have kind of the side effects of high doses of radiation. So there's not really a big difference in side effects because they both deliver radiation in a safe format. So can you repeat the names of the 2 types of radiation? So again, these are very generic names. They're not the names of the machines or anything like that. Radiation therapy is the multi-week dose of radiation, and stereotactic radiosurgery is the focused type of radiation. And among each of those types of radiation, there's a variety of companies and machines that make that can be used to deliver those type of radiation. The next question, I'm a 62-year-old female with the 1 centimeter frontal lobe meningioma. Could such a small tumor cause problems with balance? This would be very unlikely. Again, not having seen any MRI scans or anything like that, it'd be not very likely that a 1 centimeter tumor in the frontal lobe, 1 centimeter is pretty small. It's very far away from the areas of brain that control balance. So I would say just kind of not likely in this situation. Let me see. What's the outside age you'll operate on? I think that means what's the oldest patient you'll operate on? What about comorbidities such as a prior heart attack? How do we factor that? Okay, so this is a great question. So chronologic age is only one measure we'll look at. we all know patients that are in their 80s that look extremely healthy, look much better shape than other people in their 60s. So chronologic age is only one thing we look at. We kind of generally look at the overall health of the patient. Um, Comorbidities is the medical term for what other kind of medical issues do we need to know about. Like if you've had a prior heart attack, that's important for the anesthesia doctor to know when they're determining whether it's safe to put you under anesthesia. If you have any lung problems or emphysema, um, again, you may not be able to tolerate an anesthesia as well as someone without that disorder. Are you on blood thinning medication? That's an important factor to note. Um, so again, chronologic age is not the set all having, you've operated on patients in the 90s for meningiomas. Again, depends on the size of the tumor, their symptoms, and what kind of shape they're in. Okay. The question is, are meningiomas and recurrences any less likely after menopause in women? This is a great question because um, we know that meningiomas occur more often in women than men by about a 3-to-1 ratio. And we know that most meningiomas are diagnosed after the age of 50 in women. So the thought process simplistically is there something postmenopausal that makes the meningiomas come? Uh, and it turns out that a good percentage of meningiomas have female hormone receptors on them. So about 1/3 of meningiomas have estrogen receptors on them, and 75% have progesterone receptors on them. And so it's thought that potentially hormone supplements, like if you're postmenopausal and you're on hormone replacement therapy, that those hormones may stimulate meningioma growth. There's also some anecdotal evidence that the meningiomas are more likely to grow during a pregnancy when there's obvious changes in hormones there, and if you're on birth control. So if you're after menopause and you're not on hormone replacement therapy, you're less likely to develop meningiomas or have them grow than it would be if you were on hormone replacement therapy. Next question. My head pain for many years have been linked to my meningioma. About a year ago, my doctor put me on some anxiety medication. I feel I'm much better. I'm going to have MRI scans in November. The original investigation showed a grade 1 meningioma. Is head pain linked to meningioma through, though, on anxiety medication? So there's a little bit of a complex question, and again, without kind of individualized details or exam or the MRI scan, it's going to be hard for me to give a specific answer. But I can tell you that in general, about 1/3 of patients with meningiomas present with headaches of some sort. So the challenge though is headaches are so non-specific because we all have tension headaches and migraine headaches, and how can you tell the difference between a meningioma headache and a migraine headache, for example? If you're a patient that's never typically get headaches and now you're getting headaches every day, that's probably from the meningioma if that's what you have. But if you're a patient that has had migraines for 3 decades and now you're getting some more migraines and have a meningioma, it's probably not the meningioma that's causing the migraines. But on a headache that's not normal, like your normal pattern of headache, is a grounds for working up through an MRI scan. And one of the reasons is to make sure that you don't have a tumor. And there's not just meningiomas, but other forms of tumors as well. How are the venous sinuses affected by focused radiation? They're not. They tolerate the radiation well and are inconsequential. So we don't even factor the sinuses into the radiation. Um, I'm 75 with a small amount of tumor, grade 2 along the vein. how many radiation treatments. If you're being treated with like a focused radiation machine, like a CyberKnife or a Gamma knife, and the tumor's small, it's likely just be a single treatment, about 30 minutes. And I presume that's what it's just very small. So again, it should be just a single treatment. Next question is HRT, hormone replacement therapy, safe with history of meningioma? Getting back to what we talked about before, if you have a meningioma, hormone replacement therapy is thought to potentially increase the chance of a tumor growing, a meningioma growing. It's different if the tumor's already been radiated, like if the tumor is radiated 10 years ago and now you go on hormone replacement therapy, that's a much lower risk of the tumor growing because presumably it's been radiated and killed by the radiation. Um, on the other hand, I've had patients with meningiomas untreated that I've followed on MRI scans, and they've done the hormone replacement therapy for 5 years and not shown any growth in their meningioma. So obviously, every patient is different. There's no one size fits all here, but in general, there is a concern that hormone replacement therapy may, and again, may um, increase the chance or rate of growth of a meningioma. But you have to factor that risk in with the side effects that can come with menopause. And there are some patients that have pretty significant side effects, and the hormone replacement therapy really gives them their life back. And so it's not as simple to say, don't necessarily take hormone replacement therapy if you got just because you have a meningioma. I have an AVM, which stands for arteriovenous malformation. It's an abnormal cluster of blood vessels, post resection of a 5.6 centimeter meningioma. Is this common, and what are the risks of this? So the answer is this is not typically common, but removing a large meningioma from the lining of the skull can predispose a patient to have vascular malformations, more commonly what's called a dural fistula. So this is not something that is very common. I think the likelihood of it occurring is well under 1%. So it's a very unusual finding post-resection. Somebody wrote in 30 gray and 5 doses. How far apart in time are they usually given? Again, this is very, I mean, this is missing a lot of information. We don't know about the type of machine. We don't know the what's called the dosing plan or anything like that. But in general, when you're talking about radiation, the radiation is delivered on consecutive days. So Monday, Tuesday, Wednesday, Thursday, something like that. Next question, 36 years old. I have a meningioma that was discovered during pregnancy. My symptoms showed up, and within 5 days, I had symptoms in my right eye and numbness in my face. I have a skull-based meningioma affecting the vision nerve and some of the nerves innervating my face. I was advised to proceed with surgery and radiation. However, I decided to wait, and after the pregnancy hormones went down, all my symptoms went away. MRIs don't show any further growth of the meningioma seems to be the same size. Would you recommend to proceed with surgery and radiation even though the symptoms disappeared? Um, so again, I'll give you some general answers here, not kind of seeing the films here because there's no discussion of size of the tumor here. What we do know is you're 36. That means you have many, many decades of life left to live. And if you already have a meningioma at 36, it's likely, not 100%, but likely that you're going to develop additional symptoms over time, meaning that it's, if we assume you live another, let's say, 8 decades, it's not likely you're going to get 80 years of additional life without this meningioma showing growth at some point along the way. So the question is, do you treat the tumor now when it's the current size and you're not having any problems, or do you take your chances and wait and see if the tumor um, hopefully doesn't change, but more likely over 80 years, it's going to at some point show a change. It's going to result in symptoms. And then you're going to have treatment on a much more urgent basis with a larger tumor that will be potentially riskier to treat and harder to control. Um, the next question is on grade 2 meningiomas, are there stats for recurrences following surgical resection followed by 33 sessions of IMRT? That's a conventional radiation on the tumor bed. Yeah, the statistics on this is that if you have a grade 2 meningioma and you have radiation to any type of residual, the long-term control is pretty good, usually about in the 80s in terms of percentage, 80%. There's some variation to this because grade 2 meningiomas, to some extent, that type of grading system of a 1, a 2, or a 3 often oversimplifies the gradient of tumors. What does that mean? That means in the real world, there's not just a 1, a 2, or 3. In the real world, there's a 1.8 and a 2.3 and a 2.7. And so just because you have a grade 2, does that mean a 1.8 got rounded to a grade 2 and a 2.4 got rounded down to a grade 2? So there is some variation, but for your general case, I would quote about an 80% long-term control with your situation. Is stereotactic or conventional radiation best, especially for someone over 75? That depends completely on what the MRI looks like, size of the tumor, location of the tumor, and symptoms. In general, all things being equal, the stereotactic focused radiation has a higher kill rate on the tumor. But conventional radiation is sometimes used if it's felt that it's safer based upon the individual circumstances of the patient. And then there's some question about protons or photons. Again, that's not important because they both deliver a certain dose of radiation. The example I usually explain to my patients is if you're an egg and boiling in a pot of water, if you're the egg, all you see is a certain type of temperature in the water. You don't know if on the outside of the pot it's gas or electric. You just see a certain temperature. So proton, photon, that's irrelevant because what the tumor just sees is the energy level. It doesn't know whether the source is a proton or a photon, just like the egg in the pot of boiling water doesn't know whether it's gas or electric on the outside. It just sees a temperature. So really, the tumor is not going to say, oh, this is a proton or this is a photon. What the proton and photon does is it delivers a dose of energy, radiation to kill the tumor. The next question is, the webinar is effective. Could it be extended to other types of slow-growing tumors? So this is the meningioma support group. We do have other support groups for other types of tumors like acoustic neuromas. We have support groups for malignant tumors. They're all on the Stanford kind of brain tumor website if you're interested in learning about that. Next question. I have a parafalcine meningioma and a mutation and a new diagnosed NPC. Should there be a concern for the meningioma given radiotherapy is the planned course of treatment? And I get this is with limited information, and it's not clear to me why, whether or not surgery was discussed. It's not, I don't have the size of the tumor or symptoms. But this is, with the mutations and the NPC diagnosis, this is going to be a very individualized recommendation that we're not going to really be able to do over a general webinar. Any standard intervals for multiple sessions of focused radiation treatment. They're done on consecutive days. So if you have focused radiation of 3 sessions, it'll be a Monday, Tuesday, Wednesday, for example. Let's see. It says somebody had grapefruit-sized calcified meningioma and never took birth control pills, and the estimated tumor started growing a decade before menopause and never had hormone replacement therapy. Yeah, that's certainly possible. We see meningiomas in younger people that reach a certain size that make us think that they've been growing for a long time. If there's calcium in the meningioma, that usually implies that um, that it has been there a long time. Most people that have meningiomas are not on birth control pills or hormone replacement therapy. So when we talk about those are kind of anecdotal studies out there. Um, with two thin remnants of tumor left, why would 6 weeks of radiation be suggested? I'm asked to choose proton over photon radiation. I like the least invasive treatment. Okay, so the proton photon we've already talked about. There's no difference there. Um, they just dial in the exact same dose of radiation into both machines. In terms of why somebody would use 6 weeks of radiation if there's two very small pieces of tumor. You mentioned you have it's a grade 2 type of tumor. Um, it depends what's shown on the MRI scan. If you have a grade 2 tumor and the margins of the thin slice of tumor are not well defined, they may be choosing 6 weeks of radiation to make sure they cover any poorly defined margins. The focused radiation does rely on the surgeon's or the physician's ability to identify a sharp border. And if you cannot see a sharp border, even if there's a thin remnant of tumor left, the focused radiation does run the risk of potentially missing some of the tumor and then having it grow back. So that's potentially why 6 weeks of radiation could be recommended in that point. The next question is, I have a small spinal meningioma in my spinal canal, less than 1 centimeter at the C1 level, so right at the base of the skull. I'm 40 and healthy. Is recommend wait and watch. Are there risks worth of waiting? I expect surgery given it's small in my age, but that was not recommended. And also radiation was not an option. Um, so a little bit surprised here because 1 centimeter at C1. It depends whether it's in the spinal canal itself or right outside the spinal canal. If it's in the spinal canal, 1 centimeter is actually quite large because the spinal canal is about the size of your index finger in terms of space in the in the canal where the spinal cord runs. So 1 centimeter would be a large tumor in the canal. If it's outside of the spinal canal, then it's a small tumor. Um, Whether you watch or wait or have treatment is a function of um, whether you're having symptoms, which direction the tumor they think may grow, how close it is to compressing the spinal cord, and then ultimately at the end of the day, what your preference is. In general, the two competing ideas are, on one hand, the tumor may grow very slowly or may go for a number of years without growing at all. So that would argue for maybe a watch and wait. But on the flip side, the counter argument is it's a tumor. It's gotten from nothing to 1 centimeter so far. It's a tumor, so the presumption is it's supposedly going to grow over time. And as it grows, treatment becomes more difficult. So it's a little bit of a gamble. Do you treat now when it's small and you're minimally symptomatic and the success rates are the highest and the side effects of treatment are the lowest? Or do you take a chance and hope that it doesn't grow? Now, for every patient which it doesn't grow, there's a number of patients which it does grow. So uh, just because one patient gets lucky and it doesn't grow, for every one of those, there's a number of patients who watch and it grows, and now the treatment risks are higher. One thing to keep in mind is that the ability to use radiation on meningioma is a function of size of the tumor. At some point, the tumor uh, particularly in the brain, will get too large and for radiation, and then in which case the radiation option will be taken off the table. So if you're in a situation where you are concerned that you want to go with radiation, you need to maybe do a little bit of thinking of, do you want to really wait then? Because if you wait too long, you may lose your preferred preference. So I think I got through all the questions there, and we're right at the 1 hour mark. So want to thank everybody again for attending this webinar tonight. We had quite a number of people. Hope this was informative. We will post the video on my Stanford YouTube channel for those of you that want to take a look at it again. Thanks again, everybody. Have a great evening, and we'll see you next time. Bye-bye.